Hi everybody, welcome to the latest podcast from the World Association for Disaster and Emergency Medicine. My name is Erin Smith and I sit on the board of directors and I'm also the convener of the Psychosocial Special Interest Group. In this podcast, we are exceptionally lucky to have with us a long-time friend of Wadham, Professor Frederick Burkle Jr., or who many of us will affectionately know as Uncle Skip. Now, Professor Burkle is an American physician who's known for a long time for his a massive amount of work in human rights, international diplomacy and peacemaking, humanitarian assistance and disaster response. If I spent the entire podcast reading out your bio, Skip, it would take up the entire time we have allotted, so I will leave it there. Suffice to say, thank you so much for joining us to discuss your perspectives around global health, and we're also going to touch on the World Health Organization as well, being such a contemporary topic. So welcome, Skip.
Well, Erin, thank you. Thank you so much, and it's a pleasure to be here. Like everybody probably listening to this, they've been deluged with reading so many articles. They're coming out in every single journals that never had anything on infectious diseases before, and it's hard to sort of keep up. But, we gravitate towards diseases as healthcare providers because that's what we know about. But there's so much more that's going on that really is impacting what we do on a daily basis. But let me just start off reminding you that, whether we're physicians, nurses, pre-hospital personnel, administrators, everybody that's involved in the care of patients today, we've all been trained in a one-to-one relationship with our patients. That has always been emphasized. Quite honestly, I'm 80 years old, but I don't ever remember having a lecture in medical school on pandemics, and I suspect that even those that are in the last couple of years really haven't received that because the emphasis is on the one-on-one kind of situation. Now, what has changed is that with an outbreak and then an epidemic and a pandemic, we move toward population-based medicine and management, which is the analysis of and provides population-based measures that really saves the most of the population at the expense of the individual. All right. This is often a hard concept to recognize. I think a lot of people who have taken care of patients maybe did not recognize that this was population-based until some decisions were made regarding who would get treatment and who could not. I think our first indication of this came out of Italy. Now, I have to say that after SARS, I wrote an article on triage in pandemics, and the Italians did use my triage scheme. But to everybody's surprise, it was a category there of not survivable. And the Italians were faced with that, with their decisions. Matter of fact, for a fair amount of time, I don't think it exists anymore, but at their peak, if somebody was 60 years of age and required some respiratory care, they were just not admitted. They were sent home to die, okay? And that is going to be a problem for a lot of healthcare providers as they readjust to individual care, and if the memories are fresh and will be for probably many decades, it would be the one thing that they would always question.
Yeah, well,
but it impacts...
Skip, before you move on, because that was one thing that's a lot of discussion that I've heard as well, and it's certainly an area from that psychosocial perspective that we will need to be very mindful of. There's headlines coming out recently talking about, the second pandemic will be run around PTSD. Right. Amongst our healthcare workers, and as you've just rightly touched on, you were probably the very first person who was talking about triaging in pandemics long before this COVID-19 pandemic. I've certainly used your examples with my students to talk about that ethical dilemma, and now all of a sudden we had physicians around the world, particularly in Italy, having to make those decisions in the real world. So what do you think the impact will be on them as individuals? Do they take that home on some level and think, even though the guidelines were there, I made that decision to withhold care?
Well, probably to a lesser degree than maybe we would be worried about, because I think a lot of them have learned that these decisions were compiled decisions made by a lot of people.
Right.
And so that would be the relief. But certainly, there will be a lot of second guessing, because you just don't know. After someone dies, then 5 minutes later, a respirator is then available.
Yeah.
So, but that's what it is. And anybody really, who's even been involved in war and conflict has gone through this. I mean, that's where most of my education and courses and opinions have been made that do affect, how I look even at outbreaks and pandemics, because we often have more patients than we can deal with in some areas of war and conflict, as you know.
Mm.
But it certainly impacts triage, which I gave the example. But it also impacts what we have in terms of treatment. We only have 2 treatments. One is strategic social distancing strategy, or SDS, and vaccines. And we don't have a vaccine now, and we probably won't have a vaccine for quite a while. So, the issues then are applying the population-based requirements to a population. And now we're realizing that the population doesn't understand this, or they're looking at it in terms of an individual who needs care. But quite honestly, all the studies done, and one study that was done in 2007 on the letters PNAS, looked at the 1918 and 1919 influenza that killed so many people, more so in the second hub, I will have to remind you, not in the first. Many more people died with the second surge. What we learned from that is that the only thing that did control the influenza was the social distancing strategies. But the rule is all or none. If you start taking liberties with it, you just start seeing essentially population-based care disappearing, and you're getting cases no matter what. And right now, the U.S. is certainly struggling with a political system that wants people to start opening here and there, even around hotspots and all the rest. And so, we're losing our one methodology that we have, in part also because we have a population that wants to take a pill. I mean, there has been a lot more on the news about zinc and the quinolones and whatever than strategic social distancing strategies. So it just tells us that we haven't really adopted what population-based medicine and management is. The other thing is that, all of us in medicine, we're a one-to-one patient, but we're in charge and we take care of it. But the decisions that have to be made on every patient and every single day are really multidisciplinary and transdisciplinary decisions. So we have hospital administrators and ethicists and all sorts of people involved, because that's the way it has to be in population-based decision-making. But that is still uncomfortable for many people. But, we rarely considered hospital administrators, just to take an example, as being close to us in decision-making. Well, they're really one of the major decision-makers. And in the hospitals, certainly here in the United States, many of them, are now owned by corporations. And the physicians and the nurses are owned. They're salaried by them. They're not like a university hospital or a public hospital, where it's totally different. But where there have been some concerns about whether the management is correctly, or whether they have all the proper equipment, when physicians and nurses have complained, they've been summarily fired.
Yeah.
That we have never seen before.
No, and that's certainly a real concern at the moment, obviously globally, and I know it's certainly been an issue for you guys in the United States. We're certainly seeing that here in Australia as well.
Oh, you are?
Yeah, and it's certainly been in the media. We've been hearing reports from thousands of healthcare workers have signed a letter to the state, both state and federal government, demanding to know where the PPE is and when it's coming. And as you mentioned, those sort of essentially being gagged by their healthcare facilities, saying that they're not allowed to talk in the media, they're not allowed to post on social media. And as you mentioned, Skip, that's probably something we've never really seen before.
No, we haven't. We certainly come close to it in wartime. There's no doubt about it. But the periods of time when we had to move to that were brief in time, because we couldn't get into supplies. I'm talking about war and Vietnam and things like that. But and I've certainly seen it. We are seeing that also in what I call the civilianization of war, primarily in the Middle East. And the last 13 war conflicts that we've had in this world were all civilian ones, where the hospitals were destroyed. The civilians were the ones who were being killed. We didn't have any military that was being killed. And that has led to refugees and migrants and a whole bunch of other problems in that regard. And that's a major, major change. I mean, our armies are not doing much and hasn't done much except in small areas like the hospital ships and helping to build field hospitals, and we certainly need them. But, so many things are changing simply because we're moving more and more towards population-based care. And I'm going to come more to explain that. But I do want to say something about three terms that people are confused about. One is globalization, the other is global health, and then global public health. But globalization actually is an economic term, and that was used back in the 80s and 90s to look at developing countries, provide economic opportunities for them to build up their economies, and it was good for industries in the developed world to have workers that they could pay less to. Unfortunately, I have to say, I don't want to dwell on it very much, but although it looked like it was an economic success and made a heck of a lot of people very rich, overall it was a failure. But myself and others who were interested in recognizing that the world is going in a globalized manner, whether it was electronic communications, easy communication, easy travel, and everything, that we actually tried to get into some of these meetings, but always refused. But what we were looking at is that all these advances that they were making in the developing world, what was happening to the public health infrastructure? And we're talking about food, water, energy, access, availability to medical care, energy, all sorts of things, but primarily, public health infrastructure that would keep this going. And that was just totally ignored, okay? And now globalization is on the outs. It's on the outs because a lot of developing countries did poorly. They ended up being a worse mess than when they started. Industries decided to go with one country over another. After trying them both, it was very, very confusing. I'm glad it's gone. But it really what has remained is global health. Okay, just an example. A lot of people on this phone certainly recognize Johns Hopkins, but probably the School of Public Health and the graduate schools. But I'm talking about the undergraduate school, the university where people will come after high school, and the most common major at that age at Johns Hopkins is public health. Okay. Now, half of those people will go into medicine and nursing, but half are going into public health. And they can, even in the undergraduate school, also have a dual degree, so at the end they can get their master's in public health. Because we want more and more people to understand what public health is and what essentially I use, because we're going more and more that direction, into global public health. And so, we're making changes, and we're seeing lawyers, we're seeing economists, we're seeing social workers and others getting this dual degree. So, we're going to see the benefits of that probably a decade from now. But there's something about it that certainly is happening, and it's all good. So global public health really is driven more by population-based care, the basic public health infrastructure, prevention, preparedness, which are scarce certainly in the developing world, and certainly in managing any kind of outbreaks or epidemics and pandemics. Now, as I said, we're seeing more and more of these what's called zoonotic diseases, and I don't think that has been used, but that's certainly the term that I've always used. And Sir William Osler, who certainly described this in the early 1900s and around the time that we had the first influenza. Zoonotic diseases are ones that jump from a reservoir animal to a human animal. And we're getting more and more of that for certain reasons. One is that I just have more people living on the face of the earth. And where they're living is becoming more and more dense. And as you know, probably where you all live, but certainly in the United States, we're seeing more people of color who are living closer together in smaller areas. And so they're going to be more liable to these kinds of problems. In Hawaii, we have many, many different cultures. We certainly have a lot of Samoans. But to see a two-room apartment occupied by 20 Samoans, half of which work the night shift and half of work the day shift, and then sleep in each other's beds, is not at all uncommon. But you can imagine how quickly such a disease would be transmitted in those kinds of situations. Mm-hmm. Before we had, and we have to look at the change in crises too. We had sudden onset natural disasters. They certainly have been increasing more for climate reasons than probably others. We've had public health emergencies of international concerns, yes. Epidemics and pandemics. The World Health Organization takes care of about 7,000 new ones every single year. Now, the World Health Organization is divided into regional organizations, and there are 6 of them. And one is AFRO, which contains, obviously, Africa, where most of the infectious diseases arise. But the budget that they get, really, for the infectious disease is expended within 3 to 5 months. There's just so many of them. And so that has been a chronic problem before we've really run into one that has become globally. But now what we're dealing with is both climate change and extremes. So the natural disasters that are tied to climate change are just getting much more severe. The biodiversity loss is not really understood by a lot of people, but must be, because our animal reservoirs, both that are real for us as humans, but ones that potentially could be, live in the coastlines, they live in forests, they live in swamps. They're all disappearing, and we are seeing a massive movement of so many different animals and insects, more and more to human population areas. And again, the population areas not only are dense, but really the rapid, unsustainable urbanization is just happening so quickly that it really has become unmanageable in terms of finding proper distancing and all the rest that's really needed for any of these situations. The migrant and refugee health crisis, it's been pretty darn quiet, but we do know on the Syrian-Turkish border that we do have the coronavirus. What will be interesting if they do not get hit hard, it may be because they do have some resistance from previous exposures to the SARS family of viruses. We have international and domestic terrorism, and as you remember in the beginning of this, there was a real question and some finger pointing that this was a bioterrorist issue from China, and certainly more chemical and nuclear incidents, cybersecurity, and as I talked about, this is civilianization of war and conflict. So 20 to 90% of the deaths, 70 to 90% of the deaths come from that. And all of these areas lack public health infrastructure. And one of the things that's now affecting us in the developed world is that if you have, and I've written about it and many others have too, that if there is a wartime injury in these areas now, they are totally resistant to any antibiotics. This is the first time this has ever happened.
Yeah.
But now, because these people have gone into becoming migrants and refugees, they've gone to the EU and more Eastern Europe, and there have been articles written in Germany and others where their emergency rooms are ending up with patients where they cannot treat with any antibiotics they have. So these things move around, and we can't keep them from spreading.
Yeah.
And those are all global health things. But the important thing to look at is really that these are global public health issues. All right.
So Skip, so much interesting stuff there to take in, and as usual, you're always an absolute wealth of knowledge on some of these really key issues around global health. But we've only got a few minutes left, and I'm really mindful that I know people are going to want to hear your thoughts on what's happening with the WHO. So we know that recently the World Health Organization has received some pretty significant criticisms for both really their choices of action but also their inaction, focused on the role that the organization has played in response to, well, not only just this pandemic, there's certainly been some criticisms going back even to the Ebola, their handling of Ebola.
Yeah, let me go. This is probably the most important thing, and I really was running out of awareness of how much time. But let me say right from the beginning, you need to know that WHO was established many decades ago to further international cooperation for improved public health. And as a directing and coordinating authority on international health within the United Nations, and they are sponsored by the UN, all right, and a couple of other UN agencies, but they are funded by individual countries. So this is where we're starting with one of the problems. Now, everybody just automatically gives money to the UN. During that time, they would accept donations, they would accept extra stuff from some of the richer companies. But what has happened is that countries, first the United States, but most recently China has given an exorbitant amount of money to the United Nations. So there's been a concern that they're going to be dependent on what these countries will tell them to do, and I'll give you an example in a few minutes about that. WHO inherited these tasks relating to epidemic control, obviously, and I gave the example of AFRO. Specifically, its main mandates included directing, leading, coordinating the health response during infectious disease emergencies, working with countries to increase and sustain access to prevention, treatment, and care, and all the rest. Specific international health regulations, the IHR, with timely revisions, were conceived to serve as a first step in providing specific and universal medical knowledge of a unique infectious disease outbreak. So that's the IHR, the International Health Regulations Treaty, and that's more recent. So they're on top of all the new events that occur and then refer back to the WHO what they have found. Now, WHO contains a lot of wonderful people and scientists and all the rest. Don't think they are not there. But the real issue that has come up is whether the UN is really independent, and that has been the real issue. So the other thing is that, quite honestly, as back as early last October, but certainly by January, they had the genome to this coronavirus. They didn't know it was coronavirus. And they gave it out to different countries that had laboratory availability. This is China. and one of them was the United States. But because of politics, nothing was done by the United States lab. I guess this was a decision from the top. But they had that early. Now, when it really broke out, unfortunately, China reverted to their usual concerns. And as you know, physicians were ignored. Some went to jail, some had disappeared, some were killed. But there was really a cover-up. And then there was a period of about 2 weeks where we didn't hear anything from China at all. And both WHO and the United States tried to come in and work in their laboratories, but were refused. And all of a sudden, when things got better in China, all of a sudden it opened up. WHO was invited in to do an assessment, and they did an assessment, and I would like those listening to me just to pull it up on the web because it's worth reading. It's very well written and all the rest. But it said nothing about the previous situation that China had, only in terms of how they managed the population-based requirements. Now we're knowing that a lot of that data either wasn't valid or it wasn't exactly as how it was reported. But WHO gave them a really glowing report, which everybody was scratching their hair about. And it really was probably more generated because China was their biggest donor. And so the bottom line is that the global community can no longer tolerate an ineffectual and passive international response system, nor tolerate the self-serving political interference that authoritarian regimes, so we're talking about North Korea, and we're talking about China, and we're talking about Russia, and nationalism and populism demand. And so this remains a highly integrated, globalized world when it comes to public health protections. And this is what really the directions we should go. So the only solution that I see, and I just wanted to give you a little background with that, WHO must exist solely as a treaty-based organization sanctioned by the UN and all its members. It cannot be dependent on outside financial assistance to do its work. The unique characteristics of propagating zoonotic diseases must be better known by both the medical and profession and governmental decision makers. Healthcare experts must be in charge of all health decisions, monitoring, response, and operational research, as WHO was decades ago. They can't advocate any responsibilities to individual nation states, nor to be beholden for their support. So that is the issue. The potential is there for WHO to be the singular authority, but they're going to be needed to be supported and quite generously, because as I gave the example of Afro and expending most of their money within 3 to 5 months, and now having 71% of all our new diseases being zoonotic diseases, it's going to have to be very, very substantially supported to be able to do that, but must be independent. And they can't look at these as independent countries. They have to look at this as global public health directive, every single one of them. And so that's going to take a lot more learning and decision making and all the rest. But maybe some of those people that we're training now in public health will indeed go in those directions as those positions, especially regionally, will open up.
Yeah, it's such an interesting discussion to have, but we're pretty much out of time. But I just wanted to leave you with one final question that I know it's being heavily discussed in the media at the moment. Lots of us are thinking about it. As educators, we're talking about it with our students. So we've seen recently that the United States President Trump has cut funding to the WHO. There's been lots of outcry against that. We know that the editor of The Lancet, for example, called it a crime against humanity. And I'm just wondering if you can maybe leave us with your personal thoughts, Skip, on what the impact of something like that will have. So by the US cutting their funding, what's that going to do?
Yeah, he's only cutting the upcoming amount of money, but it's criminal. It's going to have a devastating effect, and it will just drive WHO to be more beholden to other countries that are keeping their bargain. I mean, the man is not very bright. He's extremely sociopathic and narcissistic. He really doesn't understand very much. He certainly doesn't understand science. Everything is about the economy and the politics, and that has integrated itself so much in public health that that's the thing that's really scary. So besides WHO having to be totally independent and funded, and I think other countries will certainly come up and support that until we get rid of the man, but, I think one of the things that will come out of this is that we do need a world organization that's going to take care of the entire global public health system, not just one country at a time.
Yeah.
And one of the things also besides that, because of what he has pushed, is that the United States doesn't have 50 different states. We have 50 different countries, and that's the way it's being handled right now, and that's not only insane, it's malpractice.
Yeah. So much to unpack just in that final little statement there, Skip, but unfortunately we're out of time. We thank you so much, as usual, for sharing your thoughts and expertise. Everybody listens so intently whenever you talk, so we're so grateful for your time today on this very important topic.
Oh, my pleasure, and thanks for listening to me. I appreciate it very much. You guys take care. Aloha.